Hello guys, today topic of discussion is cystic fibrosis. So cystic fibrosis is very high yield topic and very important topic, but in this slide I only discuss like my main focus is towards the pathophysiology of the cystic fibrosis because this is very hard to understand, right? So what is cystic fibrosis? Cystic fibrosis is basically an autosomal recessive disease in which what happens, you have a defect in the CFTR gene. So what is the CFTR stands? So CFTR stands C for cystic, F for fibrosis, T for trans, and R for regulator. So CFTR stands for cystic fibrosis trans-regulator gene. So what does that gene normally do? So normal function of this gene is that it synthesizes a protein. So what is that protein, which is called cystic fibrosis trans-regulator protein? This protein is basically a chloride channel, right? Chloride channel. And this channel is ATP dependent. So you can say this is ATP gated chloride channel, right? It requires ATP to transport, secrete, or reabsorb the chloride ion. So now this channel do different job in case of sweat gland and in case of GIT, respiration, and elsewhere, like your pancreas and where. So in case of sweat gland, these channels do what? It causes reabsorption. In case of sweat gland, it causes reabsorb the chloride through this channel, which is ATP gated. So sweat gland causes reabsorption of the chloride. In case of GIT and respiration, it causes secretion of chloride into the lumen of GIT, respiration, pancreas, and elsewhere. So, right, this is the, I will go into detail of this thing. So now what is happening in this cystic fibrosis? I told you about the normal function. Now, when you have a defect in CFTR gene, the protein will be not normally synthesized. So you need to know what are the defects. So defects are number one, you either have a frame shift mutation, you either have a deletion of the phenylalanine amino acid, which is hydrophobic. It presents as F508. And third one, you have the abnormal post-translational process in which your protein become misfolded and cannot go on to the cell membrane to do its job, right? Frame shift mutation, deletion of phenylalanine are abnormal post-translation process. They can test it on this topic in various ways, right? Okay, so now I'm come to the next slide, which is like a normal function and abnormal function of these channels in case of sweat gland. So as I told you, in case of sweat gland, what this chloride channel is do. So this is your CFTR channel, which is ATP gated, and this is showing your epithelial sodium channel. E for epithelial and for sodium, C for channel, right? So this CFTR channel, it will do in it what it does it do in case of sweat gland normally. Normally it causes absorption of the chloride. Absorption. So chloride from the lumen is reabsorbed into the cells, right? The chloride is reabsorbed, like let's say this is your skin surface. So chloride is reabsorbed, so sodium is also reabsorbed through this epithelial sodium chloride channel, right? So what is happening in your sweat? You have decreased amount of chloride and sodium. Your sweat is salty, right? Normally it is salty, but it is not too much salty as it is in case of cystic fibrosis. So keep it in mind. So chloride is reabsorbed along with the sodium and water. So this is normally happen in case of sweat gland, the job of the CFTR chloride channel. Chloride is reabsorbed along with sodium and the water. So now what is happening abnormally? So I show over here, this is this protein, this channel is abnormal. So what is happening? Chloride is normally reabsorbed. Over here, chloride is not reabsorbed. So chloride stay on the skin surface, as you can say. And also this sodium channels. So as chloride is not reabsorbed, sodium will also stay on this side. So what would be the net result? You have increased chloride, increased sodium, increased water on your skin surface. So whenever you have the sweat, your sweat have high concentration of sodium and chloride. You can say salt on your skin surface. So what would the patient present? Patient present like the complaints like she said, I kissed my child, but I feel like he feels so salty when I touch, when I lick or his skin, when I kiss the baby, right? So that is the presentation. So she wants to test it that is everything okay. So that is the presentation. On the skin you have high sodium and chloride. So that is what happened in case of sweat gland, where this channel is reabsorbing the chloride along with sodium and water. Now, what is happening in case of airways, GIT, and elsewhere? Pardon for my diagram. So, what is happening over here? So, I show you over here the bronchi and all that and lungs. So, I get a small section over here and showing you what is happening in case of lung cells. So, here I'm making another cell line so you can better understand. So, this part is showing cilia over here. So, cilia, and this is the lumen in between. So normally what happen in case of, normally I'm talking about, so normally in case of airways, this is a little bit different, so you need to pay attention over here. So normally what happen, the chloride is secreted into the lumen, right? So chloride, this CFTR is your CFTR channel, which is chloride channel, it be gated CFTR channel, right? So it secretes chloride into the lumen, and here the job is a little bit different, that CFTR channel also causes tonically inhibition of this EN, ENAC, which is epithelial sodium channels. So in case of respiration or GIT, chloride is secreted into the lumen, and this epithelial sodium channel is tonically inhibited. So what is happening? Chloride is secreted over here. So sodium stay over here along with the water, right? Sodium stay here along with the water. A very little amount is going back into the cells, but mostly sodium staying over here. And this thing make you confused. That chloride is secreted into the lumen, right? And this channel, epithelial sodium channel, is tonically inhibited. So major amount of sodium and water stay over here in the lumen of your bronchi or the respiratory tract. So what is happening when you have sodium, water, and chloride? You have mucus over here, right? So this mucus remain hydrated because of this water. And you know, when you have sodium and chloride, this is salt, and salt is always drawing the water. So that is basically mechanism for the hydration of the mucus inside of the respiration, right? So this is normal. So what is happening in case of pathology now over here? As I told you, when you have a gene defect, so what is happening? This channel is not working. Here you go. So this channel is not working in case of airways or GIT. So what would be happening? Now your chloride will stay inside. So chloride will be stay here. It is not going into the lumen. I'm making another cell layer over here. So you understand this is the lumen. So normally what happens? So normally, as I told you over here, chloride is secreted over here, right? Normally what is happening? Chloride is secreted. This channel is tonically inhibited. So you have high concentration of sodium and water over here, which make the mucus hydrated. Now over here, what is happening? Your channel is now not working due to mutation. Now chloride will stay inside, right? So when this channel is not working, so what actually happened? When this channel is not working, this channel, which is sodium against sodium, epithelial sodium chloride channel, which it is not inhibited, because normally it is inhibited. When it is not inhibited, what will we do? It has higher concentration. You can make big arrow, high concentration of sodium and water movement inside the cell in case of respiration and GIT and elsewhere. So when you have no chloride is secreted over here, because of the no channel is here, this channel, sodium epithelial sodium chloride epithelial sodium concentrated channel, epithelial sodium channel, it is not tonically inhibited. So a lot of amount of sodium and water is reabsorbed over here. So what happened? The mucus which is over here in between, it is become dehydrated. It become thickened, right? It becomes thickened and attached over here. And that thickened mucus is basically the source of infection, right? Source of infection, and it is cannot clear, because this mucus is very important, because you throw these mucus are out along with the debris, pollens, and all that stuff, even the your bacteria if it get inside. But that when this is thickened, it cannot, like, you cannot throw it out, right? So because all of here it is a dehydrated type of atmosphere, right? This is happening in the GIT also, and this is happening in the pancreas also. So that's why the enzymes are staying inside, right? As you can say, in case of pancreas, you have trypsinogen. So trypsinogen need to be secreted out to get converted into trypsin, right? So in pancreas, what is happening? Trypsinogen cannot come into the duct because duct is clogged by this thing, right? So that's why you should the test is increase immunoreactivity against the trypsinogen, which is a screening test in babies. I will describe this one later on. So what is the picture of the extracellular fluid? The extracellular fluid have the same picture as the as the patient is using the loop diuretic, because loop diuretic, they are acting on the thick ascending limb of loop of Henle. And what does they do? They causes inhibition of absorption of sodium chloride potassium. So sodium chloride potassium along with the water stay on in the luminal side of the nephron. So that is the same picture. So ECF have loss of sodium and chloride, and along with why the sweats, sodium chloride, sodium and water is loses into the sweat, and along with there is a loss of potassium and hydrogen also. So ECF picture is similar to the this loop diuretic picture. That is one point. And there is a contraction alkalosis in this topic. So what is contraction alkalosis? As you are losing the chloride, right? You are losing the chloride. So what is happening inside the body? The chloride and bicarbonate are regulated. So bicarbonate and chloride, they always regulated with each other. So whenever body don't have chloride, the bicarbonate come out, and when the body don't have chloride, the bicarbonate will become out. This is like vice versa. They balance each other. I'm showing over here one cells of the body. So what is happening when you are losing the chloride, right? So cells don't have the chloride. So what does it do? It reabsorb the chloride into the cells, into the body cells I'm talking about, right? So when the body is reabsorbing elsewhere chloride present, because you are losing higher amount of chloride into your body fluids, into like over here, into your sweat. So what is happening? Body is reabsorbing chloride elsewhere. So what is happening? The cell will in exchange excrete the bicarbonate. So that's why when you lose the chloride, you will lose the sodium, you will lose the water. So that leads to the contraction, means you are losing the water. And when you're losing the chloride, the bicarbonate in the body cells, they come out in exchange for the chloride. Chloride will go into the cells. So that will produces contraction, loss of water and sodium, and bicarbonate come into your body system that produce the alkaline media, and that is called contraction alkalosis. That is one point I want to explain you over here. Then how you can diagnose. So diagnosis is made one by increased chloride in the sweat of the babies, which you know that they are testing for the chloride concentration in the sweat, and that is increased. Secondly, they do the nasal post potential differences. So one is increase, let me write over here. One is increased chloride in the sweat. The second is the in, increased nasal. So nasal transepithelial transepithelial difference, which I come later on this point. I will explain you this one. And the third one, they do the genetic testing. Genetic testing. And other test I told you about the increased immunoreactivity against trypsinogen. So in trypsinogen, I told you that your pancreatic duct is coagulate. So it is blocked. Trypsinogen cannot come out. So they do what they causes reaction against this trypsinogen. So if it is a trypsin, so this will not produce reaction against trypsin. But if you have higher concentration of trypsinogen in case of cystic fibrosis, immunoreactivity will be high, right? Immunoreactivity will be high against the trypsinogen, which show the positive result of the cystic fibrosis. That's genetic testing of the CFTR gene. That is what happened, and this is nasal transepithelial potential difference and increased chloride in the sweat gland. So these are the diagnoses. So what is the nasal transepithelial difference? How it is produced? So as I told you, in case of the respiratory epithelium, so this is your cell. So what is happening in case of respiration? You are secreted the chloride, right? Normally you secreted the chloride over here, and this sodium channel is tonically inhibited. So sodium stay over here, chloride stay over here, and this is all that normally happening. But in case of cystic fibrosis, what is happening? You are not secreting the chloride, so chloride stay over here. Sodium is channel is not tonically inhibited, so a lot of sodium is moving over here inside the cell, right? That is the in case of cystic fibrosis. So this is all happen in your respiratory tract. So what is happening when you apply, because your nasal mucosa, they're talking about the nasal transepithelial difference. So what is that? When you apply the sodium chloride hypertonic saline to the, let me draw over here so you can understand this one. So let's say these are the cell in the nasal mucosa. So when you apply the saline, high amount of sodium and chloride to the nasal mucosa, so what would be happening? The chloride and sodium concentration over here. Sodium, you are applying increased amount of sodium, chloride and sodium. So what is happening? This channel is muted. Your chloride is here. So chlorides cannot move inside, right? So chloride concentration is increasing over here. But as I told you, when this channel is mutated, this sodium epithelial channel is what? It is tonically inhibited. So what does it happen? Whichever sodium you are applying here, it go inside. It rapidly go inside because these channels are open for this sodium. It is not tonically inhibited. So this will produces a difference, that is your chloride concentration on the nasal mucosa side is increased and your sodium go over here. So negativity on the nasal mucosa side is increased, which give you the difference between the sodium and chloride concentration. Now sodium is inside the cell and increase chloride outside of the cell, right? So that is produced to increase nasal transepithelial difference, which is the diagnosis for the cystic fibrosis. So the last point is the treatment. So treatment is what you give the patient, you do the physiotherapy on the patient, right? Then you give the albuterol, which is bronchodilator. You can give the aerolosed donase alpha DNase. You can give the inhaled hypertonic saline. So hypertonic saline again, what does it do? It causes draw of water and make the mucus increase. Sodium chloride, like saline, when you give, it causes increased water draw and which leaves your mucus hydrated and you can clear that mucus. You can give the N-acetylcysteine, which is causes breakage of the mucus. It is mucolytic and it's hard to clear out the mucus. Then there are very different treatment, like you give the azithromycin in case of infection. In case of pancreatic deficiency, you give the lipases to the patient. And also some drugs you are give in which you have ava kefter and lumacaftor. I just want to explain this one with the mnemonic that avacaftor as I. So it do what? It promote the chloride channel to the cell membrane of the cell. So avacaftor I. So it transport the I channel, ion channel or the chloride channel or opening of the chloride channel avacaftor. And lumacaftor have a lu, that is lumen. So what it does? It causes the transport of the protein toward the cell surface. So it transported. So avacaftor open the chloride channels as ion channel, and luma has lumen. So it transport the protein on the cell surface of the cell towards the lumen side. So this is how they help in the clearance of the cystic fibrosis. Thank you so much. Hope this topic helps you all. Thank you.